Hello, and a very warm welcome from the International Society for Neglected Tropical Diseases to today's ICENTD Connect. It's the very first one for 2026, welcoming this year's World Neglected Tropical Diseases Day. The brilliant advantage of marking a World Day in January is that for the tropical disease community, the year starts with really high energy, an opportunity to take stock of progress, what have been some of our milestones, and of course celebrate partnerships, but also reflect on what this community thinks are the salient points to focus on, how and what do we want to talk about as a community, but also how to share this with the wider world, how to connect with other health and broader global agendas. So welcome. Thank you to everyone who's joining online. I see we have a lovely group and lots of colleagues joining from around the world. If you're used to ICENTD Connect, you know we would love you to say hello in the chat and tell us which organization, which country you're talking from, particularly for this slightly joyful occasion around World NTD Day. So on the one hand, we're here to celebrate the fact that 58 countries out of a target of 100 have eliminated at least one NTD, often in extremely challenging contexts. That's a real testament to the bedrock of NTD progress, grounded in these really unique private-public partnerships. But at the same time, how do we accelerate this progress when concurrently some fairly strong headwinds stand in the way of the road ahead? And among those, one very close to ICENTD's heart is the alarming rise of vector-borne NTDs, such as dengue, chikungunya, leishmaniasis, and Chagas disease. Vectors can really turn into the silent accelerator of transmission, even when progress is made controlling diseases, and also shape where diseases spread, who's affected in communities, how severely health infrastructure is stretched. So at the same time, in addition to limiting disease, addressing vectors can also leverage important collaborations, whether with WASH, community engagement, urbanization, surveillance. It can be a very decisive lever in the effort against NTDs, which ticks those important 3 pillars in the WHO's roadmap to 2030. So that's why today at ICENTD, we're really excited to welcome a fantastic panel of speakers and take a little bit of time to learn all about how and why tackling vectors is not only important, it's not only urgent, but it's very much the domino effect for NTDs. And so I'm sure everyone will join me in welcoming very warmly our panelists for today, who over the next 90 minutes will share with us some very important pointers, examples, lessons learned, and just generally giving us a better idea of why we really need to prioritize vector-borne diseases and why this week, World NTD Day week, is a really good time to be talking about that. So just going around my screen, it's a huge pleasure to welcome presentations and thoughts from our speakers. We will hear from Ben Simon. Ben, hi and welcome. You're nice to meet you. On my screen, you are top left. You're head of global medical affairs at Bavarian Nordic. Thank you for making time for us. It's also wonderful to welcome you, Diana Rojas Alvarez. You are with the WHO, the WHO's Global Arbovirus Initiative, but you're also the acting interim head of the Emerging Zoonoses and High Impact Epidemics Unit, and that sits within the Department of Epidemic and Pandemic Management. Also touching on health emergencies programs, co-leading on this really important global arbovirus initiative. Diana, as always, you carry many hats, but I think that's a real symbol of how vector-borne diseases, particularly arbovirus, touch upon so many very important health issues. So thank you for being with us. We also welcome Seth Irish. You are a technical officer with the WHO's newly named Malaria and Neglected Tropical Diseases Department. Welcome and thank you. bringing us the perspective from PAHO and advisor on all things neglected tropical diseases and vector-borne diseases. It's a huge pleasure to welcome you, Ana Luciañez. Thanks for making time. And last but not least, wonderful to have you here with us, Dr. Kwadwo Frempong. Thank you so much. You are a research fellow at the Noguchi Memorial Institute for Medical Research in Ghana, and you're also president of the Pan-African chapter of the Ghanaian chapter of the Pan-African Mosquito Control Association. So enough from me. Thank you all for being here. Thank you for everyone who's joined online. And without any further delay, let's hear from some updates around vector-borne diseases. Why is that so important in the NTD landscape? What can we do about it? And what do we need to be thinking as we look to the future? Seth, I will invite you to open our session. If anybody has questions or comments or wants to share any of their work in your own fields, please don't hesitate to jump into the chat and let us know. We'll have time after our brief presentations for a really nice discussion. So without any further delay, another very warm welcome to everyone on the call. And Seth, over to you. Thank you for being with us.
Great. Thank you so much, Marianne. So I will just give a quick talk on the integration of malaria and NTD vector control. First of all, would like to wish everyone a happy NTD day, and recognizing that we have over 20 diseases that we consider NTDs at WHO, which several are vector-borne. And so very happy to talk about that today. I will start with talking about some recent changes at WHO, and then talk a little bit more about integration of vector control tools, as well as challenges and opportunities related to that. So first of all, starting at WHO, as many of you know, we had substantial funding cuts over the past year or so. And in response to that and other factors, we went through an organizational reorganization. And as part of this, the global malaria program and the neglected tropical disease departments were combined into a single unit, which is now called the Malaria and NTD department, or abbreviated at WHO as MNT. This department has 3 units: the Prevention, Diagnosis, Treatment and Care unit, the Strategic Information for Impact unit, and the Vector Disease Control, Elimination and Eradication across sectors unit. And I will mostly be talking about that last one, as that's where I'm working. As you can imagine, there's a number of vector-borne diseases that are covered by this new department, including malaria, Aedes-borne viruses, lymphatic filariasis, human African trisominosis, leishmaniasis, Chagas, Onco, and others. But actually, even before this reorganization at WHO, we were trying to increase the integration of disease control methods in WHO documents. So in 2023, we had an operational manual on indoor residual spraying that was put out, and it wasn't just a malaria control manual as it had been in the past. But as you can see, it's really focusing on all the diseases, all the vector-borne diseases that IRS can prevent. We're thinking about vector control guidelines and how we can implement those, taking into consideration all vector-borne disease, not just malaria or dengue. And we are planning for revision of key documents like the IVM manual and the Global Plan for Insecticide Resistance Management, with more of that integrated focus. So despite the circumstances which pushed the integration of our departments, the integration of vector control is something that we've been working on, and this gives us a better opportunity to continue that work. So in terms of the integration of tools, how do you do this? I mean, first of all, as with many things, we say you have to focus on the biology and the behavior vector. This is really a recurring theme in vector control, but you really have to understand when your vectors are biting, where when they're biting, where they're biting, and even how, like thinking about whether vectors are resting. And for integration of vector control, you need to think about where you can control potentially 2 or more diseases at the same time. killing two birds with one stone. And in order to be able to do this effectively, you need to think about all aspects of your control work, not simply, does IRS kill leishmaniasis vectors and malaria vectors, but also thinking about what insecticides are available to do that. And can you manage the resistance in different populations with the same insecticides? And this will inevitably cause some challenging situations where you may have a very effective tool for one disease, but it may not be the same or provide the same level of effectiveness for another disease. So how do you get the best results for what you have? In addition to choosing the vector control tool, there's also other areas where you can have significant benefits from integration, including laboratory work. So if you have a high-performing molecular lab, that can serve multiple purposes, not just for one disease. If you have teams that are well-versed in identification of mosquitoes, it's much easier to train those same teams for identification of other vectors. And so thinking about how you share your lab and molecular identification resources between diseases. Community workers are in the community and working on sensitization and other health-related activities. And of course, this is an area where you can integrate control of multiple vector-borne disease. And then just other things like transport. If you have a team going out to collect vectors of one disease, they could potentially collect vectors of another disease. Leadership. A lot of times you have countries that have a malaria program and a dengue program and a leishmaniasis program, and thinking about where the actual management within ministries of health or other organizations might take advantage of integrated leadership. And then surveillance systems. So if you're building up an entomological surveillance system or even a disease reporting system, think about how those could be integrated for multiple diseases. And one of the big tools that I think have not exploited as much as we could is health economics, which can be really useful in thinking about how you implement vector control, which vector control techniques are the most effective and most cost effective. But of course, there's still big challenges remaining to this. So, what is the value of surveillance in a program, or what is the value in preventing the spread of vectors? These things can be more challenging to model, although not impossible, with health economics methods. And of course, this is really important during these times when you have low availability of funding. So some of the challenges and opportunities related to integration is that you have the possible of reversal of progress if your integration results in watering down programs. If you just keep the same number of staff and expand the number of diseases, that can lead to a reduced amount of attention or expertise for each disease, and so you can have some backtracking in the progress that is being made, as well as the focus that can be lost if people are trying to focus on multiple things at the same time. As somebody who's terrible at multitasking, I can appreciate that very well. And there may also be situations where, because people really want to integrate, that they may over-integrate. And an example I use for this is that if you have teams going out to collect, let's say doing human landing collections for malaria vectors, which involves staying up all night, it might be unrealistic to expect them to also do collections during the day for ADs or other vectors, because at some point the teams have to sleep. And so I think thinking about integration in a realistic way is very important. But there are clear advantages to integration. I mean, you can save costs through all the methods that were mentioned earlier. You can have better communication with local populations. If you have one team going out one week and saying, do this for malaria, the next week somebody goes out and says something a little bit different for leishmaniasis, that can be an issue. Whereas if you're integrating the communication messages, this can really help people to understand where they can have an important role in decreasing the spread of that disease, of multiple diseases. And then from the insecticide aspect, of course, we want to use insecticides as little as possible. And so thinking about the insecticide use in this more integrated way can help for better stewardship of insecticides, preventing resistance in multiple species of insects at the same time. And so I will end there, but I just think that it's an exciting time, especially for us at WHO, working on integration, and the limited funding is actually a spur to try to conduct our activities in a more cost-effective way. And I think integration is a big part of this. So I will say thank you very much, and appreciate your attention.
Big thank you to you, Seth, and also congratulations on bringing these two very big departments together, and it looks so far so good, and also very much for highlighting the impact of the biology of the vector, not just on disease, but also what it means to all the way down the chain of how to tackle them, how to deal with them, how it impacts the sleep of the technical teams trying to deal with them. That was really interesting, and particularly when there's a recurring mention of the dwindling expertise in vectors, and maybe that's something we can come back to later. But thank you so much for setting the scene for us. And perhaps now we can travel to the PAHO region. Anna, we would love to hear your insights and updates from your perspective, moving away perhaps from the arboviruses and diving a bit more into some other vector-borne NTDs themselves. Over to you, Anna. Thank you.
Thank you very much. Can you confirm you are seeing my screen?
Not just yet.
Not yet.
We can see you and hear you very well, which is
that's good.
Yeah, that's a good thing.
Let me check. That's it. No, isn't it?
Yes, absolutely.
Thank you very much.
Thank you so much.
Good morning, everyone. Thank you for the opportunity to present today the experience of the Americas on controlling and eliminating vector-borne NTDs. I'm Ana Luciañez. I'm the regional advisor on neglected tropical diseases at the Pan American Health Organization at the regional office that are based in Washington, D.C. Well, today I will share with you the progress, the challenges, and the opportunities we face in controlling and eliminating vector-borne NTDs across the Americas. This is the overview of the presentation. Well, despite the sustained effort by countries, vector-borne diseases remain a major public health challenge. As you can see here, the region of the Americas continues to face a hard burden of arboviral diseases, including dengue, Zika, and chikungunya, and most recently the spread of Oropouche virus. Also, parasitic and bacterial vector-borne diseases such as malaria, Chagas disease, leishmaniasis, and yellow fever persist, affecting vulnerable populations and require coordinating responses. Well, which are the barriers and challenges? Unplanned urbanization creates a big challenge. Rapid growth often leads to inadequate water supply and poor waste management, creating breeding sites for vectors. At the same time, intensive use of chemical insecticides has led to resistance in vector population, reducing the effectiveness of traditional control campaigns. This combination makes controlling vector-borne diseases increasingly complex. Well, this is a picture of Venezuela. Well, other main challenges is the environmental change. Deforestation, large-scale construction, and unplanned land occupation directly affect the natural habitat of vectors, contributing to the expansion adaptation to new environments. These processes are closely linked to climate change, including rising temperatures and altered rainfall patterns, which particularly affect population of important vectors such as Aedes aegypti, Anopheles, sandflies, triatomines, and among others. Human mobility is another challenge. Constant movement of people facilitates the spread of pathogens across regions and making prevention and control more difficult. There are also gaps in integrated surveillance, especially in remote areas, which can delay outbreaks detection. And finally, social determinants play a key role. Vector-borne diseases disproportionately affect population living in poverty with limited access to housing, to clean water, and sanitation, and these factors amplify the disease burden and complicate control effort. Well, but at the same time, we have important opportunities to strengthen prevention, control, and elimination effort. Let's go to see them. The implementation of new tools, such as the sterile insect technique, Walchavia-infected mosquitoes, or deltametrine impregnate collars for dogs in areas with high transmission of visceral leishmaniasis, or the use of artificial intelligence for predictive outbreaks modeling. Also, update vector surveillance in vulnerable areas where the community health workers are involved to detect the presence of vector early and alert health systems and services in a timely manner and prevent large number of cases. Use a real-time epidemiological surveillance system and mobile application to support community-based reporting, and also sustain global interest in the neglected tropical disease agenda. This is very important to facilitate financing opportunities and international cooperation. We should not miss the opportunity to strengthen NTD programs by working across disease and sectors. As Seth was saying, the integration is key. Integrate activities help us optimize the use of limited resources and reach more communities effectively. Adapting the One Health approach allows us to address human, animal, and environmental health together, taking the root causes of transmission. And finally, equity and sustainability are key. We need to engage in intercultural dialogues with communities to understand their needs and design prevention and control activities that are culturally appropriated and impactful. Well, and what factors that influence the progress? The PAHO initiative for the elimination of communicable diseases, launched by the Pan American Health Organization in September 2019, and approved by the member states, is an initiative that provides a common framework to eliminate multiple communicable diseases, 30 diseases, and another related factors that we want to see later, through 4 integrated lines of actions applied across the life course and strengthen health system while addressing social and environmental determinants, with equity, human rights, and vulnerable population at the center. The initiative provides a regional framework, as I was saying, to coordinate the 4 and to promote integrated strategies at the country level. The PAHO Disease Elimination Initiative has encouraged countries to develop integrated elimination plans and road maps covering multiple diseases. Here you can see in the map some of the countries that already launched officially their plans or others that are in progress of making one. Intergovernmental working groups have been created to coordinate this effort. Importantly, as countries have incorporated broader social determinants into their plans, such as housing and sanitation, recognizing that the impact on disease transmission is not only health, there is other factors. This process has required close interdepartmental and interinstitutional collaboration to ensure strategies are comprehensive and effective. Well, these are the diseases included in this elimination initiative. As you can see here, related to vector-borne diseases, it includes malaria, Chagas disease, leishmaniasis, lymphatic filariasis, onchocercosis, and trachoma. There is also some other diseases that are for control, no elimination, that is dengue, and other arboviral diseases. The initiative has helped shift the focus away the selecting or prioritizing individual diseases and reinforcing the idea that all target diseases are equally important and should be addressed through integrated elimination strategies. Well, through the elimination initiative, a wide range of resources have been developed and are been in 4 languages, and everyone can use them to support the countries in achieving their elimination goals. One important example is the development of this, the best buy that you have here in the slide. These are evidence-based and cost-effective actions that clearly shows what works and deliver results in real setting. The best buy help decision makers prioritize intervention while promoting integrate and people-centered approaches rather than disease-by-disease action, as I was saying before. They have also become a useful tool for advocacy and accountability, facilitating dialogue with governments and partners around concrete achievable actions. In addition, the initiative has supported the creation of a regional monitoring system, including a dashboard that allows countries and partners to follow progress toward elimination targets in real time, and you can access to it through the internet. Well, collaboration is also key. So to solve collaboration, that means cooperation among countries, allows countries in the Americas to share experience, best practices, and vector control technologies. Strategic partners contribute technical expertise and financial resources to regional action, enable more rapid, coordinated, and standardized responses. Well, and in summary, success in eliminated vector-borne disease depends on integrate and coordinate vector control approaches across diseases and sectors, the use of innovation, data, and predictive tools to guide timely action, sustained political commitment and adequate long-term financing, a strong commitment, engagement, and equity-focused strategies, and countries and communities and partners working together toward a shared goal. Ultimately, reaching all affected populations, especially the most vulnerable, is essential to achieving and sustain control and elimination. And thank you very much for your attention. Bye.
Thank you so much, Anna. What an ambitious scope of work. We're very excited to see the progress, and thank you also very much for highlighting communities in every step of the way of the work that you do. This is really fundamental to tackling vectors right where they are. Thank you. And that provides a wonderful introduction to Dr. Kwadwo's presentation, who will be, you will be taking us to Ghana, where there's been some really successful combination of vector control and MDA programs. And we've seen a lot of progress in the control of several neglected tropical diseases. So we will be very happy to hear from you. There's also been a lot of talk in the chat box. So please, if anybody has any meetings or any suggestions of where else we might continue with these conversations, please don't hesitate to throw any workshops, conferences, anything that you might be organizing or attending. It would be really lovely to bring those together at the end of the call. But for now, over to you, Dr. Kwadwo. Thank you for being with us.
Thank you very much. So I'll be looking at the need to target vectors to strengthen mass drug administration outcomes. My name is Frempong. I'm a medical entomologist and a research fellow at the Noguchi Memorial Institute for Medical Research. So I'll begin with some challenges with MDA. We know that MDA has been in existence for a while, and this has helped to reduce disease burden. But then there are some challenges that MDA continue to face. Now that we have the disease targeting elimination, you don't often find most of these infections within the community. And there's a perception that in the community, there's no infection. This has affected treatment outcomes and treatment that we have within the communities. People don't participate in MDA. We know much about that. So there's a bit of non-compliance because the disease is not being seen within the community. And this also affects low treatment coverage. But I know as we are discussing challenges with funding, there is a need to look at sustainable ways of supporting this MDA. So MDA alone cannot achieve elimination. Why? Because the treatment doesn't look at all those at risk within the endemic community. It focuses on looking at those eligible, and this is by age. Now, if you even take those eligible, you can talk about individuals who are not involved because they may be sick, they may be pregnant, or there are other issues surrounding why people don't take the medicine. Sometimes individuals also don't take it because in certain communities, they know that if you've taken alcohol, then it can affect the metabolism of the drug. So there are certain situations where the individual will say, we won't take the medicine because we've taken in alcohol. That is also a challenge. And then we also have recently observed that there is poor response to the adult worm. Taking an example from onchocerciasis, we have some parasites that repopulate. The adult worms repopulate faster in the skin. Because the treatment doesn't kill the adult worm and it kills the microfilary, we have adult worms that are not responding optimally. And so within 3 months, some of them recover from the effects of the drug and they repopulate the skin. These are some of the challenges that we know that focusing only on MDA may face. So in a community where you have high density of vectors, transmission even may be ongoing, even if you have high treatment coverage, and that is because there are reservoirs and we have new infections coming up. So how does the vector control fit into MDA? So MDA basically is distributing the same medicines to the population at risk, regardless of infection. And we know vector control is supposed to reduce vector density and also reduce the contact with humans and disease transmission. So if you have the vector control, which is helping to reduce the force of infection, that is helping to reduce the number of new cases that occur within the community, and then MDA also reducing the existence of parasite load, then together we know that this can help break the chain of transmission faster than is expected. I'll take some examples from onchocerciasis where vector control has been used to support MDA. So I would like to highlight here that we don't really need to implement very expensive method for vector control, like what was done by the OCP using aerial larvicidin with helicopters. But there are very simple tools available in a form of traps, or we can even employ the environmental modification, which have been used to support MDA in other countries. So for example, we have the Esperanza widow trap that has been used mainly in Mexico. You can see the picture on the right. And it's a sticky trap that it has a blue and black stripe. Now the color attracts the black flies, so it's normally placed between the breeding site and the community. So once the flies emerge from the breeding site, they get attracted to the material, and because of the sticky nature of the material, they get stuck on it. We also have the Belek sticky traps, which is normally used to trap gravid black flies, and these the trap is placed on the river, especially where you have the rapids, where you have the movement of the water very fast flowing, and that is the area where the black flies would like to lay their eggs. So once they see the trap, it serves as a support for laying the eggs, and so they land on it and get stuck on it. And these have been used to support MDA in other countries. So we can also talk about the slash and clear, which is used mainly in small to medium rivers. And this has been used in Uganda. We know about the Uganda story, where they've been able to eliminate some infections of onco within some of the foci. Now, what happens is that the vector, once it lays in the water, the larvae needs support, and normally they support with the leaves that are found in the rivers or with the branches. And so once you are able to slash and clear this vegetation, you get rid of the larvae, and that has helped. I also want to cite an example of onchocerciasis control using dams that were built in Ghana. For example, there were 2 dams built that helped to control onchocerciasis within those endemic areas. We can talk about the Pond and the Bui dams. And once these dams were built, it reduced the movement of the river, and then it controlled onco. Even though with the, for example, with the pond, it eventually resulted in schistosomiasis infection within the community. But as far as onco is concerned, it was able to control it. We also have ground larvicidin, which has been used in areas where you have high density of black flies. And this is very helpful, even though it's expensive. It doesn't have to be applied throughout the whole year. It can be applied when you have high density of black flies. Then we can talk about repellents that are also utilized. So vector control for LF has not been documented much in Ghana, but then it leverages on malaria control, which has been done extensively in Ghana. So in Ghana, we have a well-structured vector control for malaria. There is a national insecticide resistant monitoring that was established since 2015. And as part of the partnership with the National Malaria Elimination Program, we've been able to establish that there's a high resistance of pyrethroid across the country. And through our findings, we informed the control program to be distributing PBO nets and then dual AI nets, which have been in existence. And that is just to take care of the resistance of the pyrethroid that we observed in the country. Then there is indoor residual spraying that has already been implemented, and larval source management. So currently we have about 28 districts with the implementation of indoor residual spraying in the northern part of Ghana. We also have 261 where there is distribution of bed nets, and 158 where we have implementation of larval source management. And as you can see on the top right, you have one of the agents doing the larval source spraying. These have helped to reduce malaria parasitemia in children within the northern part of Ghana, and there are evidence to show that. And also, after 7 years of implementation, there was a reduction in transmission within the northern part of Ghana, which has also been shown. Then we, as a team, Vector Research in Noguchi, we've tested a new formulation of repellent that is able to protect Anopheles mosquito bites, about 80% protection. Finally, I would want to highlight the impact of using treated mosquito nets for sealing rooms. This was an LF control intervention within the Western region, where it was realized that most of the housing structure had a lot of gaps within the eaves, and also the windows didn't have any mosquito net. And so the project sought to seal the windows with the treated mosquito net, and also to have a ceiling within the rooms. And this reduced drastically indoor resting Anopheles mosquitoes. So even though this has been done, the impact on LF basically has not been done, basically looking at indoor resting. Then we also have example from vector control in schistosomiasis. So in terms of molloxidine, this has not been documented in Ghana, but we know that the Volta River Authority has supported with clearing aquatic vegetation within the Volta River to control schisto. And there's also an example from the Adasawasi community within the eastern region, where there was schisto infection, but then when Water Creation Center was created, the children were encouraged not to be swimming in the river or to be swimming in the water body, which was infected. But then because they had a recreational center to swim in it, it also reduced the schisto infection within the community. So in summary, MDA alone cannot achieve elimination because there are challenges. And we know that vector control is important to boost the impact of MDA. We can talk about very simple control measures that will need community mobilization. And this is something that can be implemented. And so operational research, strengthened surveillance, and community engagement are very central to scaling integrated approaches. So let's treat the human reservoir with the drugs, but let's control the vectors to reduce new infections. Thank you very much. I would like to acknowledge the International Society for Nuclear Tropical Diseases, and also the Vector Research Group at the Department of Parasitology, Noguchi. Thank you very much.
Thank you so much, Kwadwo. That was a wonderful presentation directly from the field. And I think you summarized so eloquently in just that one last sentence. We've been trying to say much more in a much more roundabout way, but treat the human reservoir with drugs, control the vectors to reduce new infections. And that is how progress can be sustained in NTDs, but also averting future threats. So thank you very much for making that, giving us some very concrete examples. While you were speaking, I was reminded of a wonderful film that I had the chance to watch a couple of years ago called The Fly Collectors. I don't know if you were featured in it, but it really gives a lovely tone and view and insight into what it takes to make this kind of control happen over decades in a particular area, in a particular community. So thank you so much. Thank you, Anna. Thank you, Seth, as well, for talking to us quite broadly around vector-borne NTDs and giving us so many insights. And now we'd like to move on and perhaps focus just on one of the small bullet in the list of NTDs which focuses on arboviruses, namely dengue and chikungunya, although it was lovely to see in Seth's presentation that other arboviruses, Zika, is potentially maybe yellow fever, although that's a bit separate as well at WHO, but getting a much more holistic view of arboviruses, so that'll be interesting to see how that evolves. But for our last two presentations, from Diana and from Ben, we'd like to really focus on arboviruses, dengue, chikungunya, some of the NTDs that have dominated headlines, particularly in 2024, unprecedented outbreaks with images being shared of the government having to deploy military field hospitals in a capital city in Brasilia when there was a big dengue outbreak a year or so ago. There was things really that were unprecedented. And what does this mean when, on the other hand, you're really trying to control and make substantial progress on NTDs? So it's a pleasure to hand over to you, Diana. Subsequently, we'll hear from Ben. But we'd love to hear about what's happening in these very complex, complicated diseases. How can we respond better? And what does the NTD world need to be really thinking about? Diana, thank you for being here. Over to you.
Thank you very much, Marianne, for the invitation, and it's great to see all the progress that has been made in the other neglected tropical diseases. Early in my career, I saw several patients with Chagas disease, leishmaniasis, onchocerciasis. So it's really good to see all the progress and to celebrate World NTD Day today. So I will be presenting it. I will be giving an update on dengue and chikungunya, which are part of the neglected tropical diseases list, but are the ones with the highest epidemic and pandemic potential. So I would like to highlight that, and we work very closely with Seth from the Malaria and Neglected Tropical Diseases Department, and from the emergency department at WHO, we are keeping a very close eye on dengue, chikungunya, and other arboviral diseases. It's still neglected, but it makes it to the news way more than the other neglected tropical diseases. I usually start my presentation with this map because it illustrates really well the impact and the spread of these diseases. We have more than 130 countries with dengue transmission. So in this map, you will see in blue the countries where there is co-circulation of dengue, Zika, and chikungunya, 3 of these viruses. Then in green, you will see the countries that have transmission of 2 of those viruses simultaneously. And in the other colors, you will find countries where there is just chikungunya or just dengue transmission. But you won't see a single country where there is Zika transmission, but there is no transmission of the other 2. What I also want to highlight here is the current estimated population which is at risk for these Aedes-borne arboviral diseases is 5.6 billion. And keep this number in mind because by 2013, there was an estimation that the population at risk was 3.9 billion. So in almost 12 years, the population at risk increased almost by 1.5 billion. And this is due to many things, such as urbanization. We have the vector adapting and expanding and arriving to new areas, not just in latitude, so it's going north in Europe and also south, but also in altitude. So and now we find the Aedes mosquitoes even higher and higher in the mountains. So let's say that 20 years ago in some areas you could find Aedes aegypti at 800 meters above the sea level, and now it's found up to 2,200 meters above the sea level. So that also increases all the population that hasn't been exposed before to these viruses, and it makes them susceptible to infection. We have the increase in temperatures, we have the changes in the environment, which are also helping the transmission of these diseases. So I want to highlight that because we have more than half of the population, the world population, is at risk of these arboviral diseases. As Marianne mentioned, 2024 was a record year for dengue, with more than 14 million cases reported and 10,500 deaths also reported from 107 countries by WHO. It was declared a grade 3 global emergency, which is the highest level of emergency that we have at WHO. When we activate the country levels, we activate the alarms, and then also in the regional levels, and it goes up to the global level. We had in 2024 182 countries and territories reporting to the WHO global surveillance. And we were able to quickly build a surveillance dashboard that is been with updated data since then. You will see here the cases by each of the regions, and don't think that the region of the Americas has almost 13 million cases is because there is necessarily way more transmission there than in other regions. There is a case, the case definitions vary by each of the regions and also the ascertainment varies substantially between regions. So for example, the region of the Americas, they report cases in suspicious or suspected cases, probable cases, and then confirmed cases. But there are regions such as Southeast Asia, which are just reporting the hospitalized and confirmed cases. So that's when you really see the differences. We've been working with the regions and with the countries on standardizing these case definitions. So when we compare the regions and we compare these numbers, we are really comparing like a similar case definitions. In 2025, there was still a transmission from what was left from 2024, with more than 5 million cases reported and almost 4,000 people died due to dengue. And the report was done from 104 countries. Most of the countries that started reporting cases in 2024 continue with the transmission of and the reporting during 2025. Here again, we have the largest number of cases from the Americas. However, there was transmission all over the 6 WHO regions. Here you can see the epidemic curves by each of the regions. So here, well, now that we are capturing real-time data, we can see a bit of seasonality when we see a peak in the African region in September, or almost at the beginning of the second semester of 2024, and a similar behavior in 2025. The same Similarly, in the Eastern Mediterranean region, so the seasonality in Africa and Eastern Mediterranean is very similar. In the region of the Americas, most of the transmission happens in the first semester, but also keep in mind that in endemic countries, the seasons are getting longer and they are starting earlier. So it's been very challenging for some of these countries to do preventive activities, because it has become a new challenge when to start these activities, because they used to start, let's say, in December, because the season was going to start in January, February, but now in 2023, the 2024 season started in at the end of October. So this is also bringing some challenges in the transmission dynamics. Then we have the Southeast Asia, that is the opposite to the southern hemisphere in the Americas, where the dengue season is after the monsoon season, which is in the second semester of the years. And then the Western Pacific region has endemic transmission all year long. Here you will see all the islands and overseas territories that are located in the Pacific. But what I want to summarize here is that we have dengue transmission in all the 6 WHO regions. Here you will see a map where the darker the color, more cases were reported in 2025, with most of the burden of disease in Central and South America, Southeast Asia, and as I mentioned before, the Western Pacific. During 2024, also, there was a record number of cases from the African region reporting dengue to the global surveillance system. Here, it has another view of the impact of the cases, of the amount of cases. But here we have incidence rates by 100,000 population. So still, Brazil is the country that reports most of the cases. And even when we do the incidence rates, Brazil highlights as having also a high incidence rate. Then you start seeing more these countries in the Western Pacific that probably you didn't see them in the previous one, because their islands, the population is small. So when we just count cases, we won't be able to actually see the real impact in the population. But here you can see them clearly. It's because they are a bit darker, so you can see them in the map. We have Guyana here, which is in a very dark red. And then you see the African countries and other countries in Central America and South America with also a large incidence rate. So as you saw with dengue, we have several challenges in vector control, the expansion of the vectors, and of course the increasing temperatures. Now let's move to chikungunya. So chikungunya virus is also transmitted by Aedes aegypti and Aedes albopictus. It is in 115 countries have reported chikungunya at least once in history. And here in this map, you can see the countries in orange that reported a transmission of chikungunya in 2025. It was a different and challenging year for chikungunya. 20 years ago, in 2005 and 2006, there were reports of very large outbreaks in the Indian Ocean and affecting almost 2/3 of some of the islands in the Indian Ocean, the overseas territories from France. And it was the time that the world became aware of the risk of chikungunya virus. Chikungunya virus was found in the 1940s, and it was circulating in the African region and somehow in Southeast Asia. But right after that outbreak, we understood much better the impact and the long-term effects of chikungunya infection. So 20 years later, basically, chikungunya came back to the Indian Ocean and cause extremely large outbreaks also in some of these islands, affecting again 2/3 of the population. So we are talking about almost 300,000 people infected in some of these countries or territories. There was a importation of cases into continental France, and again, a very large outbreaks in China, in the Western Pacific, and Southeast Asia. However, with chikungunya, we have a challenge on surveillance, because as it has been considered a neglected tropical disease for a long time, some of the reports are annual, just for programmatic views in how it's being controlled or based on the goals that have been set in the neglected tropical diseases roadmap. However, every time that there is an outbreak, it becomes an emergency. So that's when we work very closely together with our colleagues from NTDs, and for us, it's a priority to start also having updated and the most real-time possible data on chikungunya. And we are working very closely with our regional offices, and they are working very closely also with the countries to ramp up a little bit the chikungunya surveillance. So this is a quick summary of the cases. So from the Americas, almost 300,000 cases, 38% of them confirmed, most of the cases from Brazil, a very large outbreak in Cuba with almost 40,000 cases. It happened last year, and the outbreak is still ongoing, followed by Bolivia and Argentina. And there was the first autochthonous case in the New York State in the US also last year. From the African region, there were cases reported in Mauritius, Madagascar. There was an outbreak in Mombasa in Kenya. Senegal and Comoros in the Eastern Mediterranean region, some outbreaks in Pakistan and Somalia. In Southeast Asia, cases, chikungunya is endemic in India. It had a comeback in Sri Lanka, outbreaks in Bangladesh and in Thailand, and in the Western Pacific, there was a very large outbreak in China, in Guangdong, in the province of Guangdong, with almost 30,000 cases confirmed. Indonesia, Philippines, Malaysia, and Singapore. And in the European region was also a record activity in mainland France, with almost 800 autochthonous cases in continental France, plus the 54,000 confirmed cases from La Réunion, but it's estimated that it was about 250,000 cases. So in 2025, it was considered a year with high chikungunya transmission, and we keep monitoring closely the situation. Please also keep in mind that the population that is more susceptible to severe chikungunya are the elderly population, people with comorbidities, and pregnant women, because chikungunya can have vertical transmission during birth. And we really keep an eye on that, because when chikungunya is severe, the case fatality rate can be even larger than the case fatality rate that we see on dengue. So for the last 4 years, we've been working on the Global Arbovirus Initiative, which has 6 pillars on monitoring risk and anticipation, reducing epidemic risk, strengthening vector control, strengthening preparedness and pandemics, enhancing innovation and new approaches, and building a coalition of partners. But as Seth mentioned, we also went into a change and looking for synergies and ways of doing things. And I will explain that later on, and how the Global Arbovirus Initiative will evolve. So most of the achievements have been in monitoring risk and anticipation. So now we have the global dashboard that you will see the link there. Please visit. There is a suitability map for Aedes-borne diseases, where you can zoom in into your country or your city and see how much risk of transmission is there. We had the chance during the emergency also on updating several guidance on arboviruses. The clinical guidance for dengue, Zika, chikungunya, and yellow fever was updated. Then we work on tools for risk communication and community engagement. We also had interim guidance on laboratory testing for dengue. And there was also a dengue expert review panel for diagnosis, where 9 different diagnostic tests were evaluated and were approved for pre-qualification at WHO. We have several challenges, so I just mentioned here the ones that are in the NTD list, but there are other arboviruses circulating, so the job is, these have never made it to any list. So these are the most neglected because no one even keeps them in mind. But here is where Malaria virus, West Nile, Oropouche, and others are, and we are still keeping an eye on that. So on the next steps, we will be expanding the dengue dashboard to Zika and chikungunya. We will be working on more analytics for the country so you can take decisions based on data. We are working on implementation of different products in the regional and country level. During the reorg here at WHO, now we have a very strong global arbovirus program that has 2 flagship initiatives. One is the Eliminating Yellow Fever Epidemic Strategy, and the other one is the Global Arbovirus Initiative. And they will come together into a global arbovirus strategy. We still don't have the name for that, but it will be a stronger strategy moving forward. We are aiming to launch by the end of this year. So it will start at the beginning of 2027. So stay tuned for that. And we will be inviting you to participate and to provide feedback and doing in the consultations, because for us it's really important to hear every single voice from the ones who are in the field, in the ministries of health, and in the different levels, so we can really have a strategy that will help the preparedness, prevention, and control of these arboviral diseases. And we are currently going through funding constraints as many other programs on public health, but we keep going. We keep finding synergies and innovative ways of keep battling these arboviruses. So with that, I want to thank you for your attention, and over to you, Marianne. Thank you.
Thank you so much, Diana. You've asked us to stay tuned, and I'm sure everybody will. So many resources, so many things that you are rethinking and organizing for the vector community. So thank you. It's a huge and impressive amount of work to track, survey, keep a tab on, respond, and organize all these different stakeholders across so many different and unpredictable diseases. So thank you for your presentation. Thank you for your work. To be continued for sure.
Thank you.
Before we move, thank you. And before we move to the questions that are building up, and just a quick note that if anyone wants to jump into the Q&A box and maybe has some answers or comments to contribute, we can also start having that discussion there as well, in writing, as well as later on verbally in the webinar. So please do go ahead and do that. And now to conclude our session, bring this all together, it's really my pleasure to hand over to you, Ben. Ben, you are representing Bavarian Nordic. We're very proud to say you are our latest member, and it's a happy coincidence to launch a collaboration right in World NTD Day week. And really giving a great example of the bedrock of NTDs, this inherent collaboration between industry, research, programmatically, the communities and the people affected. And this has never been more urgent to come together than around chikungunya. So we're excited to hear more from you. How can vector control accelerate and thwart NTDs? Over to you, Ben.
Thank you so much. And I'm really proud and really happy to be here with such a distinguished panel. As part of Bavarian Nordic, we're very proud also to contribute to the fight of several indeed tropical neglected diseases, and to also to be collaborating with you. So today I thought I would focus more on chikungunya. Dr. Rojas was already talking a bit about chikungunya in the context of specific challenges and complexities. And I thought I would add my 2 pence also in terms of where the key challenges and gaps are and prevention, and where we can really have the most value in collaborating and working across different sectors. One of the key things we were discussing already is chikungunya is in fact expanding. It's being found more often and in places where it was not before. And this is due to a number of factors. We've already touched on them, but aside from the obvious, climate change is allowing for new biological niches for Aedes mosquitoes in parts of the world where the mosquitoes were not present before. We also have a virus that is able to adapt. Chikungunya is caused by a single-stranded RNA virus. And we've seen some mutations that have really increased the ability and the fitness of the virus to replicate, also in Aedes albopictus, so in areas of the world that are relatively temperate. And then, of course, we have increases in population, we have mass migration, movement of people, international trade of goods, and these have all driven transmission of chikungunya and increased stochastic risk of introduction of chikungunya into new environments. But one thing that is really essential to know when we talk about chikungunya is that outbreaks are still unpredictable. There is a lot of work that is going on to collect information, to collect data, and to simulate and predict what the next outbreak might look like, where it might happen, and when. But the thing is, today, even with the information that we have available, we are not able to really accurately predict what the next outbreak is going to be and where it's going to be. And this is due to a number of factors. Perhaps one of them is the fact that chikungunya so far has been mostly burdening countries with low resources. And of course, with that, it comes with the limited ability to collect data points and to be able to really feed simulations and models. Another thing that is relevant is that we don't really have biological markers that will be able to predict accurately if an outbreak is going to be more or less severe and what it's going to look like. So this is some really fascinating stuff in terms of epidemiological trends when it comes to chikungunya. But one thing that we all agree on, and I've seen this has been also presented before, is that chikungunya cases are substantially underreported for a number of reasons. We talked about chikungunya official numbers being reported annually are in the ballpark of 400,000, 500,000. But there is a recent publication on Nature that estimates that the real numbers of chikungunya annually might be in the region of 35 million, which is really a far cry from what is being officially reported. And again, this depends on a number of reasons. But again, we have underreporting, we have underascertainment. There are, of course, issues and limitations with the availability of affordable diagnostic kits for chikungunya in many parts of the world, limitations and to the infrastructure of surveillance systems and reporting systems. But also, one thing that is worth mentioning is that even when it comes to the severity of chikungunya and the burden that it has, we still don't have the full picture. What we see is that in areas where you have outbreaks, there is an increased morbidity and mortality in the months following the periods of intense transmission. In the same way, you could say, for example, for flu or for RSV or for COVID. But again, this isn't really captured in a systematic way. We don't have treatments available for chikungunya. That's the next issue and the next gap. So, of course, we have some palliative care that can be given during the acute phase to help manage pain or to help manage the inflammation. But then when you look at the chronic side of chikungunya and the arthritic manifestations of chikungunya that burden probably 40% of the people who get the disease, there isn't really an approved protocol for its treatment. Now we're starting to see more and more that rheumatologists are treating chronic chikungunya arthritis in the same way that they would treat, for example, rheumatoid arthritis or other autoimmune diseases. So with immunomodulatory drugs or with immunosuppressants. But this is, again, something that we need to work on, and where we need to establish protocols and evidence-based treatment schemes. So this, obviously, I'm talking to a lot of people who work in public health. I'm also a field epidemiologist by background and a public health specialist. This is even more important to talk about prevention. And here I only listed some individual prevention methods for chikungunya. Obviously, insect repellents, the use of long-sleeved shirts and pants, and then, of course, behavioral patterns such as removing stagnant water from habitations or introducing screens of windows wherever possible. We also talk about sleeping under a mosquito net, but the important thing here is that Aedes mosquitoes are diurnal animals. They bite during the day. So this type of measure is only useful if you have already chikungunya, you're in bed, you are protected, and that prevents further spread. But sleeping under a mosquito net will not prevent you from catching chikungunya. So I think we've all seen also from our own experience, avoiding mosquito bites is difficult. And we talked a lot also about vector-based public health control methods. And we see sometimes that these can be suboptimal. They are complex, they need to be introduced every year, and they are expensive. On top of that, there are also now 2 approved vaccines in some parts of the world. And of course, where these are approved and when they're indicated, they can be also an additional tool to help protect individuals who are at risk of exposure. So before I wrap up, I've listed here just some of the gaps that I mentioned and some of these knowledge points where I really see that there is a large scope for collaboration and dialogue across sectors. We talked about the hidden burden of chikungunya, both in terms of actual numbers across the world, but also in terms of the severity of the disease and the long-term morbidity and mortality. We talked about the health and economic impact that the chikungunya can have on communities, both in terms of quality of life loss, but also in terms of economic losses. Of course, outbreak prediction and preparedness are a big area of growth and development where we have still knowledge gaps. And of course, we still don't have approved treatments, but also there is a gap for and a need for accessible and accurate diagnostic tools, and also for diagnostic algorithms and protocols. And then finally, in my case, I work in vaccines. I think one of the most challenging and exciting areas for development in the future is to really be able to assess the real world impact that vaccines can have at some point in terms of effectiveness, in terms of safety in a broader population, duration of protection, but also in terms of implementation of prevention strategies. So how, when, and where we need to deploy preventative strategies, including potentially vaccination. So with that, I'm going to stop here, and I'm going to hand back over to you, Maria.
Thank you very much. So much, Ben. Thank you for wrapping up the session on this very comprehensive insight into the connection between a vector-borne disease and the wider global health landscape. I think this session has been amazing. It's been fantastic, and it's really demonstrated what we call the domino effect of tackling vectors, whether that be to strengthen surveillance, as we saw with Diana's presentation around arboviruses, but also engaging with communities for vector control, also thinking about what this means for insecticide management, and etc. So really a wide range of connections to the broader global health agenda. There's been a lot of questions asked as well in the chat and in our Q&A, which means we need a second webinar to answer the questions and discuss. But perhaps one to get us started would be, we've heard now as an NTD community the importance of thinking about and acting upon vectors. From your experience in your work, is there anything that, since we're having a bit of a advocacy moment in this week, is there anything that you might recommend to keep politically or just at more of a policy level to keep vector-borne diseases much more in the spotlight, front of the health agenda? Perhaps, I don't know if anyone wants to jump in. Diana, sure.
I could start and then others can add. So one of the things that we could do is to start sharing more and more and more our successes, because there have been several successes that even I work on public health and I was not aware of. So every time that we eliminate a new NTD or that we beat a target, we need to make sure to celebrate these successes. There are some diseases such as dengue and chikungunya which are more difficult to control, or even, well, hopefully at some point when we have vaccines and new tools, we will be on that track. But we need to be more vocal and celebrating more the successes of combining all these public health activities and having dedicated resources to control and eliminate diseases. That would be one thing. And the other one, from my point of view, is community engagement. So the more we engage the community, they will be able to advocate for their health, because it's their benefit. So I will leave it there, over to others to add.
Nah, over to you.
Thank you, Marianne. And yeah, I agree with Diana that I believe that include the community is essential to have impact, and sustainability of the activities that we have. And also I would add, like, it's very important to work in intersectorial plans at political level in the government. This plan recognizes that vector not only is health challenge, but also a reflection of housing condition, environmental management, climate vulnerability. So it's very important that we can tackle all these factors as well, and not only look into the disease as is the vector control. So how we can work all together in the government. Thank you very much.
Thank you. Anything to add, Ben or Seth? Kwadwo?
Yes. So I believe that, in NTDs, we haven't really highlighted the challenges that much. If you look at malaria as an example, because of the nature of the disease, there's high fatality rates. But in NTDs, we don't see a lot of death rate. So naturally, it doesn't get attracted to politicians, because these are not cases that we often hear with high fatality rate. But I think that we should also look at how we present the diseases to politicians. And so instead of using infection rates, for example, onco, instead of saying that the infection of onchocercal volvulus, we should look at risk of blindness. We should be talking more about the risk of blindness in terms of the disease. That is what they relate to. And then also research to really understand the add-on effect of vector control to MDA. We don't have a lot of data to show the add-on effect of vector control. And I think we should be doing much more about that, and to support, get more information to the politicians to know how to support. Thank you.
Really good point. Thank you, Kwadwo.
Yeah, and I can only echo that. Oh, sorry. I can only echo that from where I'm standing. I think that community engagement, knowledge, awareness are really key pieces when it comes to neglected diseases. The way that we collect information, we talked about underreporting, under-ascertainment, and of course, if you can only see, if you only have a very partial view of what the extent of the issue is, there's of course only limitations to the level of interest that there is for these kind of diseases.
Fantastic. Thank you, Ben.
I was just going to jump in and say that also when you can translate health gains to economic gains and show the economic benefit of having a healthy workforce or a healthy population, a lot of times that can be more convincing to make changes, especially because vector control tools are often very cost effective.
That's a really good point. So what I've heard from all of you, but also very much from the chat, is number one, that we need to share more. So in a week, that's all about awareness. I think that's a really good point to start from. Share our successes, as you were saying, Diana, but also share the challenges and potentially even making that much more tangible with a more robust investment business case. What will you save by investing here and there? What I heard from the chat on that topic is that there's also an appetite to share events and where we can meet more and around these issues and topics. So that's certainly a defining theme. And maybe back to the investment case, we could turn to some of the questions asked by Michael McDonald, very important ones. First of all, hi, Michael. Lovely to see you here. And Michael was saying, wonderful to see the integration of vector control operations. I think this was right at the start when you were giving your presentation, Seth. But what about funding? When can we break the barriers between Anopheles and Aedes control funding by international donors, etc.? Over to the panelists.
I guess I can jump in and say a few words about that. I think it's a great question. I mean, I think we're talking about integration and possible benefits, and funding is certainly something that can be a great benefit, but also when it's restricted to one disease can actually work against that integration. And that's why I think there's still work for us to do in terms of health funding to ensure that we're not only working towards integration from the programmatic side, but also in the financial side, which is really important and often one of the difficult parts about promoting health.
Thank you. Oh, Diana, sorry. We're new. We were on a different system where there wasn't a hand raise, and so I feel like everyone's being really polite and raising their hands, but it's probably a new feature from us switching to Zoom. Sorry, I kept you waiting there.
No worries. I think what Seth just mentioned it's extremely important. So we can create integrated approach and integrated interventions, but we also need the support and the funders to start thinking on an integrated way. So for example, for years in some areas, as the malaria fund was just for malaria, they were collecting a lot of mosquitoes and the Anopheles were taken and the other ones were thrown because there was no money to even analyze those. So we really need to start being more creative in the current financial and public health situation. We need to try to synergize more, and we need to try to see how the funds that we have for one specific disease can be also used, because when you have a trap, you have everything that's flying that is attracted to the trap will get there. So it's a great opportunity to have this integral surveillance, but if the funds are just for one specific disease, might impact the implementation of all these activities. So I think if we can drive also an integrated agenda globally, when funders give us some more flexibility, of course, not using, malaria funds to use on rubella, right? But if we are talking about vector-borne diseases, neglected tropical diseases, we could have more flexibility to actually synergize better and use the little funds that are available in a more effective way.
Fantastic. Anna, please go ahead.
Thank you, Marianne. To complement Diana's comment, it's very important as well when we speak about One Health. We all know what is One Health, but the funding goes only for the human perspective in human activities, no, for some donors. So it's important to open, no, and to see if we're going to have a sustainable control activities. We need to go to the roots, no, and sometimes is these reservoirs, no, the animal reservoir, also what we have to tackle. And something else, speaking about integration, is not only because we're gonna have less, we're gonna need less resources, financially and human resources, but also because it's a need. For example, the most expensive thing is to reach some of these communities that are in remote areas. We're talking about neglected tropical diseases. No, sometimes they are so remote that once we go there, we need to give them health, and we say health in an integrated way. No, how to give them the best that they need. And that's the important thing that my colleagues were saying today about how to include the community, because we will listen to them, what are the needs that they have, and if we want to be successful in some activities, they need to be agreed with them, and it's something that they should also work on to define what are their needs. Thank you very much.
Thank you. Kwadwo, over to you.
Yes. All right. So I want to draw some experiences from some of the surveillance that we've engaged in with the National Malaria Elimination Program. So as you may know, Ghana recorded the Anopheles stephensi in Ghana, which is a vector that is supposed to be transmitting malaria in Asia. And right after the incidence of that, the control program decided to engage in some surveillance for stephensi. But because stephensi is also a container breeding, just like Aedes mosquito, then there were plans to have an integrated system where, in addition to the Anopheles stephensi surveillance, we added on Aedes surveillance, which is supposed to be for arboviruses. So I think that this system of integration is very important, where the control program, having the funds, can leverage on that to support surveillance on for other vectors. And I think that should be encouraged much more. Thank you.
Fantastic. We just have a few minutes left, and so just picking up on something that Ben and others in the panelists reminded of about, don't sleep under a bed net if you're trying to avoid dengue or chikungunya, because it might not help. And so this was a really great reminder as to the role of entomological knowledge. Dr. Pradeep Srivastava says that we've been hearing about challenges in entomological surveillance and shortage of skilled entomologists since 1990. I confirm, when I entered the field of tropical diseases, the first thing I heard was there's not enough entomologists. And so nearly 2 decades down the line, that really hasn't changed much. Integration of human resources for strengthening public health systems is great, but is there any concrete suggestion or support to boost this capacity in the medical entomologist? How can we resolve this problem? Do you have any thoughts on that from some of your programs in communities or from what you've seen?
Well, let me start. What I can say is that the entomologists, they became a rare species. People are really not interested in doing entomology anymore. And we need them. We really, really need them, because these mosquitoes are expanding and expanding and expanding. And we need to understand the biology of these mosquitoes when they bite. I'm not an entomologist by training, I'm a clinician, but we have a gap in knowledge, and these mosquitoes, they adapt really quickly. They become resistant to insecticides. Now we have new tools, so we need to monitor these new tools and the implementation on the field. So I will encourage the young generation to keep studying entomology. I know the molecular biology and phylogenetics and phylogenomics is super important too, but there are things that the people that we serve are needing. So let's first cover the basic needs and make sure the populations are protected, and while we understand which vectors are around and they might be at risk to getting one or two or maybe more diseases, because we have areas where several of these neglected tropical diseases might be endemic just for the life conditions. So we need to also, I will encourage the entomologists to also show all the cool work that is done by entomologists. If you have been in the field with an entomologist at least once, capturing the mosquitoes, and then they look them in the microscope, and then they do the taxonomy, and it's fascinating. So if we really want to have more entomologists, and I'm talking globally, for me it's a real concern that in the field we have less and less entomology. So it's not improving. That what you mentioned, that they were less entomologists. Yes, I can confirm that. And every year the entomologists from the elimination of malaria and they are retiring, and there is not a new generation of entomologists that is ready to take that responsibility. So I would let Seth, who is an entomologist, talk about it. Seth, over to you.
I am an entomologist, and I think it's a fascinating career, and so I'm very happy to be here. But I think as my career has progressed, I've realized that actually entomology is not the only skill that's needed to implement good vector control. A lot of times entomologists lack the epidemiology or understanding of how to measure the impact or cost effectiveness of interventions to be able to advise national programs. So I would push back against the fact that we only need entomologists. We need people who can understand and make good decisions related to vector control, which does certainly have an entomological aspect, but also has things like epidemiology, understanding of how programs work, cost effectiveness, and thinking about how to design a good vector control program, not just go out and collect mosquitoes, although that is part of that work.
Any more comments to add, Kwadwo?
Yes, to add to what Seth mentioned, I think we have a model in Ghana where the few entomologists that we have supporting the program, we've been involved in a lot of training, generally at the regional, the district, and even at the community level. So currently, the entomological surveillance that we engage in have a system where we've trained individuals within the community, and they are able to do the collection and the identification of the various mosquito species. And that we leverage that on the National Malaria Elimination Program. So throughout the country, I mean, a number of districts or communities that you go in there, you find community volunteers that have been trained by us to be able to identify breeding sites and also identify mosquito species, sort them out, and then ship it through the transport to us in Accra. And that is a model that we've been using as a surveillance system for malaria in Ghana. And that can be done for NTDs in other communities. Thank you.
Thank you so much. You've all given me a great idea, which is a future ICENTD Connect, a day in the life of a medical entomologist. I know we have a few on the call already. Bridget Adupa from Uganda, please get in touch. Seth, we will welcome you back for your personal experiences, and anyone else who wants to be involved. I think that could be really exciting. Well, we've gone over by 5 minutes already. I have totally failed at bringing many of the questions to the panelists. I hope it's only the start of a really important next phase to the conversation. There's renewed momentum at WHO despite the challenges, a fresh start with departments and remits changing, and hopefully we can harness that for the future. You also have a packed couple days ahead with lots and lots of World NTD Day activities, so I don't want to hold you much longer. While maybe I ask our panelists for just one final word of advice or recommendation on how you feel, what can be done as we enter World NTD Day and the year behind it. What can we change? Would there be one thing that we can change to accelerate progress, cross-cutting progress across vector-borne NTDs? And if so, what would that be? I did want to apologize because there were two big blind spots in this webinar. One was around sleeping sickness. Diana, you spoke of success stories, and that one is not just for NTDs, but across public health, just an amazing story. I'll put a link to a film that will summarize it a lot better than me rambling on. Also, we didn't speak much about schisto, and I think it's okay to bend the science a bit. It's not technically a vector, but very interesting to see how controlling snails could boost MDA, particularly in very persistent areas. So lots of things to continue to unpack as we go along. But while I try to paste in the chat a list of events, first World NTD Day, compiled very kindly by our colleagues at the Global Schistosomiasis Alliance by Anouk Gouvras. I'll hand over to our panelists for the final word. Anything we should think about, anything we can do to really boost vector-borne diseases, collaboration success within NTDs. I don't know if you want to go in order of presentations.
I can start if you want that.
Thank you.
I think one of the things that I've realized over our past few months in integration within our department is the value of the human connections. And so just inviting somebody who's working on a different disease for coffee and discussing, oh, this is what I think about this is what we're doing. And quickly you start to see those areas of synergies or areas where you can work together. And so I think don't wait for the structural things to bring you together. Start with the human connections.
Fantastic.
Thank you, Marianne. I'm in order, so I'm just bumping up. I think we're facing a crisis in global health. So more than ever, we need to work together, no, and raise awareness. We were saying that it's very important to share experience, no, and as Seth was saying, no, to share experience among all and then learn about each other and raise awareness all together. I think more than ever, we need all to push, no, to join forces and to push. In the last mile, in some countries, in some regions, it is the last mile to eliminate and to sustain control of some neglected vector-borne diseases and tropical diseases. So thank you very much.
Brilliant. Thank you. I think, Kwadwo, you were next, but obviously no pressure at all.
Yes, so I would want to talk about policies for integration. I don't know whether WHO would want to help bring out some strong recommendations of how vector control can be an integral part of NTD prevention or NTD control, because we have a well-structured data or guidelines for malaria vector control, which is well documented by WHO. But I don't know whether we could have a similar document that can support NTDs, a well-structured vector control with guidelines to support NTD. I know there are bits and pieces here and there, but could we have one document that could serve? And these are very important even for the NTD program, to show to the ministry that there is a recommendation from WHO that vector control should be an integral part of the prevention, and that can even trigger support from the government. So I think that that strong recommendation should also come from WHO. That now we we kind of, whether mandatory or recommendation, a strong recommendation to make vector control integral part of disease NTD control or prevention. Thank you.
Thank you.
I think I'm next. And so, yes, so I wanted to talk about the sustainability and how to synergize, but someone else already said it. So my point would be intersectorial collaboration. So we need to keep insisting in working together. Sometimes from the health sector, as we are the ones counting the cases, then we end up with the whole responsibility of all the gaps that there are in urban planning, in access to water, sanitation, right? Like the basic life conditions and the activities that need to happen so we can prevent further and sustain the gains from all these elimination campaigns. So we need to work with other sectors and we need to involve them on this because we are all together on this. That will be my two thoughts to add to this. Over to you.
Yeah, and I think, Diana, you stole my thunder. I was going to say exactly the same. I see that there's always a lot of scope for genuine dialogue and transparent communication across different sectors that opens up opportunities for a lot of ingenuity, for a lot of ideas, and also to really understand where the need is and what can be done to fill a lot of those gaps. I talked about some of those in chikungunya, but that really applies across the board when it comes to neglected diseases.
Fantastic. Well, thank you so much to our panelists. A big round of applause. If we were in a room together, you would likely get a standing ovation. It's been an amazing session. I've learned so much as usual. And it was very important to us at ICENTD to really put a bit of focus on vectors as part of World NTD Day. So much to talk about, so much to cover, but we are more than happy to support with those dialogues, those cross-sector collaborations, and I'm sure the audience will join me in thanking you very, very much for giving us much to think about and for grounding us at this particular moment in time. So a very big thank you. Thank you to our audience. I think we had more than 40 countries represented, so that was really wonderful. Lots of different voices, a very active chat. Thank you to Bridget, who joined as an entomologist from Uganda, Dr. Amina, principal scientist, NIH Pakistan, Dio Gratias, investigating schisto in DRC, Gillian from UKHSA, and many, many more. I can't welcome everyone, but thank you so much for being here. Thank you again to our panelists, and let's definitely keep in touch. You have a link to many, many World NTD events later today, all of tomorrow. Also, the fantastic webinars shared by Anna and Diana on Zika and PAHO's work, and many more resources. So on that note, I wish you all very well, and I look forward to seeing you again at the next ICENTD Connect. Thank you so much for joining.
Thank you very much for the invitation. Bye-bye.
Thank you.
Take care.
Thank you.
All the best. Bye.